Hello there, everyone. Thank you for joining. We'll just go ahead and get started straight away. Hello, I'm Christina Banks from the Immunization Economics Community of Practice, and I'd like to welcome you to our webinar today on the question of what does it cost to reach zero-dose children? Next slide, please. First, I'll briefly cover some housekeeping. So please feel free to introduce yourself and to talk with other participants and panelists in our chat box at any time. You can also submit questions using the Q&A box at any time. We will be holding a Q&A session at the end of the webinar after all of the presentations have been given. And a note that this webinar will be recorded. Next slide. Our agenda today is a rich set of presentations looking at both an overview of the existing global evidence on the cost of reaching zero-dose children, as well as studies on the cost of reaching zero-dose children in Ethiopia, Nigeria, and Pakistan. Again, followed by the Q&A session. And I'd like to welcome our 5 esteemed speakers, and we look forward to hearing your insights. Next slide. Without further ado, I'll introduce our first speaker. Flavia Moi is a Senior Technical Advisor at Health Systems Insights, and today she will share an overview of the global costing evidence for reaching zero-dose children. Over to you, Flavia.
Thank you, Christina, and let's dive right in. So today I will be sharing an overview of the existing evidence on the cost of reaching zero-dose children based on a synthesis we conducted earlier this year. So first of all, who are zero-dose children and why do we need to know how much it costs to vaccinate them? Zero-dose children are those who have not received any routine vaccines, which is they're usually identified as not having received the first dose of DTP-containing vaccines by the first year of life. So these children are disproportionately found in marginalized and hard-to-reach communities and often face multiple and overlapping deprivations and vulnerabilities. For this reason, reaching them is key to improving equity in immunization programs and in health outcomes in general. So knowing what it costs to vaccinate zero-dose children is essential for adequate planning, budgeting, and financing of zero-dose focused interventions. And also to help immunization programs balance equity goals and considerations with affordability and operational constraints. Moreover, as we will see in the presentation, the cost of reaching them varies widely across contexts, and understanding differences in cost can help identify where each strategy is most cost efficient. So earlier this year, the Immunization Economics Community of Practice convened a pre-Congress meeting ahead of the IHEA Congress to share preliminary findings from the extensive body of work on the economics of reaching zero-dose children that has been ongoing for the last few years. So my presentation today will summarize the evidence on this topic that we're presenting at that meeting, as well as additional and updated findings that have been published or shared with us up until October of this year. As you can see, the evidence covers both supply-side strategies and demand-side interventions for multiple countries. So in my presentation, I will try to distill some overarching takeaways from this evidence, while the other speakers today will do a deep dive into 3 of the studies included in this synthesis. So if we look at the evidence on the cost of vaccinating zero-dose children in rural and hard-to-reach areas, we find that costs can range widely from just about 89 cents for reaching measles zero-dose children with routine catch-up, all the way to an economic cost of almost $130 for reaching zero-dose children with vaccines and with other health services through mobile health and nutrition teams in Ethiopia. So if we look closely at the evidence, we see that there is a lot of variation, of course, and that depends on the delivery strategies that were assessed, the setting in which the intervention was implemented, the type of costs considered, and also whether or not only immunization-specific costs were included in the assessment or the cost of co-delivery, other health services was also assessed. So if we overlay the number of zero-dose children reached on these costs, we also see that that is a key driver that explains the variation in costs, with strategies that reach more children also achieving a lower cost per zero-dose child reached. So what we've seen in our review is that in rural and hard-to-reach areas where constrained access to immunization services is the main driver of zero-dose prevalence, catch-up campaign-style delivery strategies such as PIRI reach more children per session and do so at a lower cost per zero-dose child reached. While these strategies are more cost efficient, exactly because they're implemented relatively infrequently, sometimes just once or twice a year or even less, they leave children off schedule for longer, indicating that there is a trade-off between reducing costs and leaving children unprotected for longer. So if these type of strategies were to be implemented more frequently, each session would reach fewer children and the cost per child reach would likely increase. So the evidence also shows that integrated delivery strategies can reach zero-dose communities with multiple essential services, including immunization in a more timely manner. While the overall cost of running these might be high, they deliver multiple interventions. And if we only look at immunization-specific costs, so only the incremental cost of delivering vaccines, then the cost per zero-dose child reached is relatively low. When looking at the cost of reaching zero-dose children in urban settings, we also observe a wide range of costs. Here as well, a lot of the variation is driven by the delivery strategy or the intervention assessed, and also the type of cost analyzed, with costs being much lower if we're looking only at financial costs, which represent additional expenditure, as opposed to looking at economic costs, which also include the opportunity costs of using existing resources. So here as well, we see that some of the variation in cost is also explained by the number of children reached, but the picture is a bit more complex than in rural areas. So what are some of the conclusions we see from this evidence on reaching zero-dose children in urban settings? While in rural areas, constrained access to health facilities and to immunization services was the main barrier to getting children vaccinated, in urban areas, studies have found a wider range of drivers of zero-dose prevalence. This means that tailoring interventions to ensure that they address the key barriers faced by zero-dose children in that specific context, that is essential to ensure that interventions are cost efficient. So, for example, in areas where access is the key barrier to get children vaccinated, then supply side interventions like adding additional outreach sessions or extending facility hours can reach more children at a relatively low cost. While in settings where barriers are mostly demand side, increasing resources to just strengthen and boost service delivery will likely not translate into better reach of children, and it might also result in higher costs. If we look at the evidence on demand side, community-based interventions, we see that costs also vary widely, from about $10 to a little over $500. And I should add that the numbers we're seeing here are preliminary results, and final results from these studies are coming out soon. So here, the wide range of costs reflects not only the different types of interventions or the different bundles of interventions implemented and assessed, but also the fact that these were assessed at different points in their implementation timelines. And also, of course, the type of costs included, and also whether the design costs or technical assistance were included in the cost assessed or not. So here we see that interventions that have been implemented for longer and have had the time to reach more children present a lower cost per zero-dose child reached. So as I said, these findings are preliminary, but the evidence that we see so far shows that while demand-side community-based interventions can be effective at tackling hesitancy and other demand-side barriers, they do require a deep understanding of the context to ensure that they're tailored to the specific barriers faced by zero-dose children in those areas. For this reason, they tend to have very high design costs, which can lead to a high cost per zero-dose child reached. However, as these interventions are implemented for longer and design costs can be amortized and spread out over more children reached, we would expect the cost per zero-dose child to go down, at least until a certain point. However, when scaling these interventions to other contexts and different locations, some sort of redesign would likely be required. And so the cost per child reach might continue to be high when scaling these interventions to other geographies. So in conclusion, we found that the strategies that reach more zero-dose children per session tend to be more affordable because they can spread fixed costs across more children reached. But sometimes this efficiency comes with a trade-off. Some of the approaches, those that are more campaign-like, might not link children back with routine services as efficiently. And so if children are only reached this way, through these strategies that are relatively infrequent, they essentially might never be on schedule. So affordability has to be balanced with how long children remain off schedule, which of course carries risks. We also observed that integrated service delivery, particularly when combined with services that are more in demand, like nutrition, can be a cost-efficient way of reaching zero-dose children. These strategies create demand because they offer multiple services all at once, and they do reach children in a timely way. And while they have high overall running costs, the cost per service delivered overall is probably low, and the incremental costs for immunization only is also relatively low. As we've seen then, findings show a great deal of variability in costs, and a lot of that depends on the context. The same intervention can be inexpensive and effective in one location, but also quite costly and not so impactful in another. This is especially true in urban settings where barriers are often more complex. There is no universally effective or universally cost-efficient zero-dose intervention. Strategies always need to be matched to the local drivers of zero-dose prevalence. Finally, we see that interventions that require significant design work often have high startup costs. And while these costs do fall over time, as interventions are expanded in new areas, there might be a need for redesign, and so costs might not go down when scaling up to different geographies. Thank you so much for your attention. And if you want to know more about this synthesis, you can visit immunizationeconomics.org. Thank you.
Great. Thanks so much, Flavia. I'd like to welcome our next speakers. We have Girmaye Dinsa, who is the Deputy Director of Health Financing at Fenot Associates and an advisor to the Ministry of Health in Ethiopia, and Abdi Gari Negasa, who is a health economist at Fenot Associates and lecturer of health economics at Haramaya University. They will share a study on the cost of reaching zero-dose children in rural Ethiopia. Over to you.
Thank you, Christina. Thank you, everybody, for joining. It's a pleasure for me to introduce this study and give you some background as well as methodology, and Abdi will hopefully go through the findings. Let's go to the next. Yeah, so just to give you a quick background, so Somali and Afar regions are some of the remotest regions in Ethiopia, and part of the communities are pastoral communities or mobile communities. So these studies happened in these regions because particularly zero-dose children are many in this region. So as you can see, Ethiopia has more than 1 million zero-dose children, and the ministry had a strategy, particularly between 2023 and 2025, to sort of accelerate access, and they name it Accelerated Action Plan to address zero-dose children. And the purpose is really to reach under-vaccinated children in Ethiopia. And there are several strategies included in the accelerated action plan to reach zero-dose children. But the cost of these strategies is not known. And the purpose of this study, therefore, is to provide evidence on the cost of reaching zero-dose children, particularly in these communities using these strategies. Next, please. So in terms of the approach, we did both quantitative and qualitative analysis. As you can see on the left side, Afar and Somali are kind of on the periphery side of Ethiopia. And so we did a costing study and collected data from these regions. And therefore, the costing strategy we did is activity-based bottom-up micro-costing. And that's from the health provider perspective. So we didn't do a patient perspective in this regard. So the cost data uses the weighted volume-weighted average, and we used the 2024 USD in the costing strategy. And we sampled 6 waradas. Waradas are districts and 17 health centers. So health centers are kind of the primary clinical providers in Ethiopia. And health posts are mostly for, they're based in communities in villages, 1 health post per village. The role is really providing preventive and health promotion care, including immunization. And we also did qualitative analysis, and we conducted 16 interviews with health workers and policymakers from the federal level to community level, including the health extension workers, to understand the context of the findings, as well as some of the operational and financial enablers and bottlenecks or barriers. Next, please. Okay, so what are these strategies we're costing? We did cost 3 strategies, including what we call routine immunization and regular outreach. These are provided by the facilities I mentioned earlier, the health centers and health posts. Health centers are responsible for providing clinical care at lower level system, as well as for overseeing health posts. There's 1 health center overseeing about 5 health posts. So they provide immunization at facility, as well as they also reach out to communities. And then the second strategy is what we call mobile health and nutrition teams. These are specifically for going around, particularly going out to remote areas and provide services, including maternal service, nutrition, immunization services in hard-to-reach areas where usually facilities are not available or communities are mobile. So mobile clinics operate 5 to 6 days per week. They spend 1 day in every kabale or village. And they have dedicated staff members as well as vehicles funded mainly by UNICEF. The third strategy is what is called periodic intensification of routine immunization, or PIRI, that Abdi will talk about soon. And it's a campaign style approach that is implemented in every warada and with strong community engagement or involvement. And by design, PIRIs are supposed to happen 4 times per year. But in reality, we found they only happen 2 or 3 times per year, depending on the resource availability. Let me stop there and give it to Abdi to go through the findings. Thank you.
Thank you, Girmaye, and everybody for joining us. And the results, when we see our results, first in terms of vaccine volume delivery, so health posts deliver majority of the vaccine doses, but in terms of reaching zero-dose children, PIRI was the most effective in reaching zero-dose children. So as we see from the graph, health posts delivered about 34,000 vaccine doses, but they reached about 384 zero-dose children, and health centers also reached about 144, but PIRI reached 646, more than combined health center and health post. and mobile health and the nutrition teams reached lower amount of zero-dose children and smaller amount of vaccine delivered, because mobile health and nutrition teams deliver many services, not only immunization, they give nutrition and other essential health service for many kabalis in a given waradas. So next, please. So in terms of costs, the total annual delivery cost of zero-dose strategy are lower than the routine delivery strategy. PIRI and the mobile health and the nutrition team are zero-dose focused immunization strategy other than the health center and the health posts. When we see their annual costs, the health posts per warada, they cost us about $21,880 per warada per year. And PIRI, when we see the PIRI, it is less amount of money per session, or so it costs about $4,290. From that, about 719 is financial costs from the total economic cost of 290 US dollars. So for the mobile health and the nutrition team, it costs about 9,739 US dollar. From that, the financial cost is about 2,366. So you can also see for the health center and health posts for the financial and opportunity costs breakdown. Next, please. So the cost in terms of unit cost per session and cost per month for each health center and each health posts. For the cost for each health post is per month is about 114 US dollar per month. For health center, it is about 349, and for mobile health and nutrition team per month, it is about 811. And you can also see from the PIRI also. Next, please. To see the unit costs in terms of cost per dose, PIRI have unit cost of about 0.64. Mobile health and nutrition team have more costly. It costs about 2.3 per dose. Health center also costs about $1 per dose. Next, please. In terms of cost driver, PIRI, the main cost driver for PIRI was per diem and delivery allowance, and for mobile health and nutrition team, labor and vehicle and fuel were the main drivers. For the static one, health center and health posts, mainly derived by labor and cold chain equipment and maintenances. Next, please. For the cost per zero-dose child reach, PIRI is the most cost-efficient delivery strategy. As we see, it costs about $6.6 for each zero-dose children, and mobile health and nutrition team was the most costly strategy. It costs about 129 US dollars to reach each zero-dose children. For the static one, health center costs about $90, and health post costs about $52. To see the breakdown of the mobile health and the nutrition team, when we see it is financial cost from the 31 US dollar per zero-dose child reached of the financial cost. The incremental cost that is only attributed to zero-dose or only attributed to immunization is 3.5. What makes the mobile health and nutrition team cost strategy higher is because much amount of costs are shared across other health systems. Next, please. So as a conclusion, both mobile health team and the PIRI are effective at filling the operational challenge and the resource gaps in the routine system because they reach many more missed children in hard to reach areas. These two strategies, mobile health team and the PIRI, are zero-dose focused strategy. So mobile health and the nutrition team and the PIRI, they complement each other, but they can't replace each other. So simultaneous use of mobile health team and the PIRI may cause resource overlap and effectiveness. And PIRI is the most cost-effective and cost efficient at reaching zero dose, though it is only implemented less than recommended average. As we found, it is conducted sometimes 2 or 3 between, on average, it can be, they were conducted 2 to 3 times per year. So many children that are reached through PIRI strategy remain permanently behind the schedule unless they are linked to the routine system. So the referral linkage between PIRI and the routine system have to be strong. And we found it is weak, and this result in the dropouts, and families also wait for the next PIRI rather than going to health center and health posters for the next session of PIRI. So, and furthermore, if the frequency of PIRI increase, it has implication on the cost, as more and more session of PIRI increase, it is cost efficiency decrease because few zero dose children will be remain in the community. And immunization specific financial cost of mobile health and nutrition team is low, and it's because it offers more comprehensive, consistent, targeted, and integrated approach for reaching vulnerable community. Moreover, the integration of mobile health and nutrition team with other services like nutrition increased the vaccine uptake for the children. So when we compare the vaccine uptake, it is increased for the mobile health and nutrition team, and the dropout also low. Next, please. I think we have finished the slides. Thank you. To see the detail of our quantitative and the qualitative finding, you can go to the attached QR codes. Thank you, everybody.
Thank you, Girmaye and Abdi, and we'll indeed be sharing all the materials from this webinar on our website afterwards. Our next speaker, Hadiza Salele, is an associate on gender programming at the Clinton Health Access Initiative in Nigeria, and she'll be sharing on the cost and impact of extending immunization sessions in Lagos. Over to you, Hadiza.
Thank you, Christina. Hi, everyone. Hope you're having a good day. As Christina mentioned, I'll be speaking today about the incremental cost and impact of weekend vaccinations. This is part of our lessons learned documentation from implementing the zero dose reduction operational plan in Lagos State. To provide some background on the next slide, as mentioned by Flavia earlier, zero dose children who have not received the first dose of the pentavalent vaccine. But more specifically for Nigeria, we are looking at the age cohort of 12 months to 23 months. And sometime in 2023, Nigeria used a lot of data sources to triangulate and also identify which local government areas have the highest proportion of zero-dose children. And 100 local governments were identified, and 2 of these local governments are in Lagos State, which are namely Alimosho and Ikorodu local governments in Lagos. Next slide. So to provide some context on Lagos State, Alimosho and Ikorodu are one of the most densely populated cosmopolitan LGAs in Lagos. And it's also important to mention that they have a continuously increasing migrant population moving from different parts of the country to Alimosho. And what that means is that they are moving in with their different health seeking behavior, which is to a large extent affecting the immunization coverage in the state. And what we tend to see in these 2 LGs is that a lot of the women are working class women. And as we know, the gender role of child care responsibilities fall on the woman in those places. And it's often found out that the women in these places prefer to take their children to the health facility, but when they go to take them to the health facility because they are rushing to go for work, they might end up leaving without seeking for that service. And what the Lagos state government did to address this issue is to introduce the weekend vaccination, especially in high volume PHCs where they can catch a number of children. So we have two categories of facilities that provided the weekend vaccination sessions. Some of the facilities provided the service for a selected number of hours, while there were also facilities that also provided the service within 24 hours. And in these facilities where the service was provided for a selected number of hours, they require some additional costs, including the cost of engaging vaccinators, engaging recorders, as well as community mobilizers who support to generate demand in the community. Moving on to the next slide. So what we intended to do was, one, to estimate the quantified effectiveness of Z-drop in reaching zero-dose children. And we also wanted to determine whether the weekend vaccinations are cost-effective. And lastly, using qualitative methodologies to gain insight into the experiences, the best practices, and also the challenges that the healthcare workers in those facilities it affected them in implementing the weekend vaccination session. And one of the challenges that I have to mention is getting the zero-dose data for the services provided during the weekend, which affected our ability to use volume-weighted numbers to estimate the number of children reached or the cost per dose, which meant that we had to use the additional dose costs incurred for the extended sessions, and also what the average number of the vaccines were delivered for each session. For the stakeholder interviews, we were able to engage local government immunization officers, the facility in charges, and conduct a thematic content analysis to synthesize the findings from this work. Moving on to the next slide, I will see what the total cost of Z-drop implementation was in Lagos State. About $154,738 were spent to implement the Z-drop. And in total, about 1,662 children were reached with the first dose of Penta during the period of implementing those Z-drop plans. And the incremental cost per dose for reaching the zero-dose children was $93.10. Also, in line with what Flavia shared, we can see that the range of the incremental cost per dose per zero-dose child reach also very significant with other studies that we have found, even though we were also not able to find any other study that measured weekend or evening vaccination sessions. But it's also important to note that there's additional funds that were spent for Z-drop were also used to reach the children with other antigens, other immunization antigens. So, which is why we also adjusted the number to see what the incremental cost is per dose delivered, which is about $34.26. Moving on to the next slide, also look at what the cost per zero-dose child reach, which is about $4.23. But as mentioned earlier, when it was adjusted to include other antigens, this came down significantly to 1.36 per zero-dose child reach. And on the next slide, we also see some of the findings from the qualitative interviews that we conducted. A lot of the stakeholders that we engaged shared the opinion that the weekend vaccination is complementary and equitable, while it's not to replace the weekday sessions or other immunization activities that are conducted. It's important to conduct these sessions so that we're able to reach these working class caregivers. Another thing is that while during the weekend, the facilities also ensure that they set systems in place to make sure that the vaccines and supplies are available. And one key challenge that we saw is because the facilities are trying to manage their wastage rates, that led them to reschedule the vaccination to work days, which led to lower number of zero-dose children reached in total. And additionally, they conducted health talks, which were used to generate awareness for the weekend vaccination. However, they've also faced the issues of the human resource gaps which led to increased workload and also burnout amongst the healthcare workers, and they had to provide the services for a couple of hours and leave the health facility. Another major issue was there was delayed release of the funds during the implementation of the zero dose reduction operational plan, which led to the inability of the facilities to properly engage community mobilizers, which affected turnout and also influence the total cost per zero dose child reach. In conclusion, on the next slide, we saw that the weekend vaccinations are cost effective in reaching the working class women, and they also complement the other immunization service approaches. But it's really important to ensure that we address the human resource challenges so that they can effectively deliver the weekend vaccinations. And it's important to also support the weekend vaccination with developing policies and also considering this as part of considerations for gender and equity. Thank you. Back to you, Christina.
Great, thank you so much, Hadiza. So our final speaker, Tahmeena Hassan, is a research manager at PHC Global, and she'll share a study on the cost of identifying and vaccinating zero-dose children in Pakistan. Over to you, Tahmeena.
Thank you so much, Christina, for the introduction. I will be sharing the results emerged from our study on the cost of estimating the cost of identifying and vaccinating the zero-dose children through several selected interventions, and also their comparison with the routine immunization program strategies in Pakistan. Christina, next slide, please. Okay, thank you. A bit background of Pakistan's immunization program. So currently, the expanded program on immunization provides all essential vaccines to the children in routine, and it works at the primary healthcare level across the country. Along with that, the polio eradication program, which is a parallel program specifically focused on polio vaccines and works through planned door-to-door vaccination campaigns implemented at national and subnational level. The country is also facing zero-dose challenges as in 2024, it was estimated that around 396,000 zero-dose children were recorded. To cover this immunization gaps in service, the country has been initiating several additional interventions which help to reaching the zero-dose children. But the success of these programs are usually counted as total number of zero-dose children reached by these interventions. The cost versus benefits were never been calculated and for these additional strategies. So in our study, the aim is to evaluate the cost and the outcomes of these special initiatives, which helped reaching the zero-dose children and also in urban and rural parts of the country. We also generated evidence on the possible programmatic and financial barriers and enablers which these programs has been facing in reaching these zero-dose children, and developed some actionable recommendations for the government that may help the decision makers to effectively plan the future immunization programs. Next slide. Next slide, please. Okay, so in our analysis, along with the routine strategies, we included three targeted interventions. These interventions were selected through a prioritization exercise with the stakeholders, and based on that scoring, we shortlisted three interventions that was included in our analysis. So in routine in Pakistan, the immunization services are provided through the fixed sites. These are the designated permanent sites at the primary healthcare facilities and operates and provides the services on daily basis. Along with the fixed sites, the routine outreach is conducted through through the vaccinators who plan routine outreach sessions regularly in the nearby communities around these primary fixed sites. So in the selected interventions, the integrated outreach, which is a campaign-styled program, and this program has additional social mobilizers which help the vaccinators to reach to the high risk or the low coverage areas. Mostly, these integrated outreach campaigns are mostly planned twice or thrice a year. The next strategy is the Clinic on Wheels, which is a very targeted program. And this program works on a model where the mobile van specifically target the underserved high risk urban areas and provide additional healthcare services, primary healthcare services such as family planning, ANC, PNC, care for the mothers, and nutritional services for the children, along with immunization services. So, along with these two dedicated strategies which are used to vaccinate the children, the country also leveraged the routine the polio program to identify zero dose children. In polio program, the vaccinators they during their routine during their polio campaigns, the vaccinators they identify zero dose children, they record them, and also share the zero dose data with the routine EPI program. Next slide. Next slide, please. Okay, thank you. Regarding the design, the study deployed a mixed method study design with the costing survey data plus healthcare providers interviews. The site for the data collection. The sites were selected based on very specific criteria, which included the urban-rural status of the district, the population density, zero dose prevalence, and the Gavi priority areas. So based on these calculations, we selected 7 representative districts, and within these districts, 26 union councils were selected. The union council is basically the basic administrative level in the country. And for the analysis, we calculated the full cost for the strategies which are only providing the immunization services, such as fixed site, regular outreach, and integrated outreach. The incremental cost was calculated for those strategies which also provide additional healthcare services, like in Clinic on Wheels and polio house-to-house campaigns. The zero dose definition which we used in our analysis is every child which hadn't received Penta 1 or any injectable vaccine by the age of 18 weeks was regarded as zero dose. Next slide. So these are the results of the total zero dose number. These are the results that the number of zero dose children identified and reached by each strategy. In the first table, you can see the total number of zero dose children reached by polio house to house campaign per day per union council in 2023 was 2.3, and in 2024 is 1.1. During these years between 2023 and 2024, though the national estimates on zero dose number was very consistent, but the results shows that, but in our analysis, that less number of children were identified through polio house to house campaign in 2024 compared to 2023, which means the polio, which could be a possible indicator of the effectiveness of polio campaigns in identifying zero dose children in the country. Next slide. So these are in the table 2, in the second table, you can see the total number of zero dose children reached and vaccinated by these additional strategies and the routine program strategies per day per union council. The integrated outreach has reached highest number of zero dose children per day, which is 1.3 as compared to other strategies, followed by routine outreach and clinic on wheels, which reached around 0.7 children per day per union council. And fixed site has the lowest number of zero dose children reached per day, which is 0.3. Next slide. So when we compared the costing, economic costing data of these interventions in reaching zero dose children, the routine outreach has the lowest economic cost, which is $39.85 as compared to the rest of the strategies. And if we compare the routine outreach only with the integrated outreach program, we can see the integrated outreach program, the major driver of the cost is additional staff, as well as the cost on fuel and transportation, which is very low in routine outreach. The fixed site has the highest economic cost, which is 58.68, and the major driver of this cost is the opportunity cost, which includes the daily, in which is the routine labor, as well as the maintenance of the healthcare facility cost. And when we see the clinic on wheels data, which is a very well resourced strategy, the major cost driver is the paid labor, the additional staff, which is the contractual workers providing these services in the specific areas for the clinic on wheels. um, for the integrated outreach, though the opportunity cost is very similar to the routine outreach cost, the major driver is the fuel and the other sources. Next slide, please. So this in the left side, in the right side, you can see for the polio program, the cost of identifying one zero dose child in 2020 in 2024 is 17.21 dollars as compared to 2023, which is $9.7, and this difference is because of the volume of the zero dose children identified in 2023 versus 2024. Next slide, please. Next slide. When we disaggregated the analysis at the urban-rural setting level and more precisely at the district level, we observed that the integrated outreach performs best in the rural environment in terms of reaching higher volume of the zero-dose children compared to the routine program. So this pattern is observed in all the rural districts on the DG Khan, the Gotki, Kambar, Shahdad, and then Bahawal, except for the Bahawal Nagar. So in Bahawal Nagar, the highest cost for integrated outreach program was due to the fact that at the time of implementation of IOA, there was a flood season, and most of the which compromised the overall efficiency of the integrated outreach. Next slide. In the So in the urban districts, in the on the other side, in the urban districts, the IOA, though extremely resourced, the performance of routine outreach is much better as compared to the integrated outreach in the urban districts. So this implies to the fact that in the routine outreach is performing better in the urban areas because of the basic because the basic healthcare facility infrastructure is much better in the urban areas as compared to the rural areas. Therefore, most of the children are already reached through the routine outreach, and the effectiveness of the integrated outreach in terms of total number of zero dose children reached was less as compared to the routine outreach. And if we specifically look at the green bar, which is the clinic on wheels results between Lahore and Faisalabad, uh, clinic on wheels, which employed only in the specific targeted high risk areas. We see in Faisalabad, actually there are informal settings where there are large pockets of zero dose children as compared to Lahore, which has more scattered zero dose population. So that's why the overall cost of reaching zero dose children in Lahore was higher through in clinic on wheels compared to the Faisalabad. Next slide. So these are the important points which emerged when we align the economic cost results with the perspectives of the healthcare providers. Uh, so though the barriers to reach zero dose children are interlinked and targeting one barrier may not be sufficient, but the effectiveness and efficiency of any intervention would be much higher when matched with the specific barrier that the intervention has the ability to cater. So, for example, we observe that in areas where supply side is weak, the routine infrastructure is not sufficiently providing services to the targeted population. IOA works best there, as the additional resources such as providing fuel and transportation and service delivery to the vaccinators would increase the reach to the unreached children and help to have more benefits. In urban areas where the basic infrastructure is much better as compared to the rural areas, the additional campaigns would create an environment of mistrust between the communities and may lead to the campaign fatigue, as the populations at the communities may get disturbed by these additional vaccination reminders and also thus reduce the efficiency of the campaign. No, in those areas where in those districts are in those communities living either at the poverty line or below the poverty line, so the fixed site is not really efficient because this cause an additional cost to the communities and the families to reach to the fixed site and for their children's vaccination. So in these areas, we observe that the conditional incentive programs would boost the cost because that could be a driver for for the communities to visit the healthcare facility and get the services. Um, the clinic on wheels between the two districts where we studied the clinic on wheels data, we noticed that in areas where the accessibility is a major challenge, providing these additional services at the doorstep would be better as compared to the other areas where the accessibility is not a challenge. Next slide. Next slide. So these are some of the key takeaways and recommendations. The context and the setting and the time of the implementation of any intervention is very important. So to be more effective at reaching zero dose children, for any immunization strategy, it must match with the zero dose barrier, as well as the outreach. For example, the integrated outreach or extensive outreach campaigns would be strategically deployed in the country where they are needed, where the baseline coverage is low or the infrastructure is not sufficient in as compared to the blanket intensification of the campaigns across the country. For
Thank,
specific interventions like clinic on wheels, so
sorry,
specific
Tahmeena.
interventions on. Okay,
Thank
all
you so
right.
much, Tahmeena.
I'm
I think just
closing.
in the interest, thank you so much. Just in the interest of time, we'll just leave your key takeaways up for a few minutes. But just to get the most out of our speakers for the Q&A, perhaps we can already start on the Q&A.
All
We'll
right.
just leave your key takeaways up for just a moment more. So first, a question for Gamera and Abdi regarding PIRI. And we've seen that PIRI may need to be a primary service delivery alternative given continued resource constraints. So just a question, how is PIRI being considered longer term, such as with microplanning and domestic funding beyond this project? So over to Gaber or Abdi, if you could respond to that.
Hi, so we have addressed that each of the questions. I believe Abdi is also addressing the last one right now, but I can read them out. So the way we answer to that is, yes, PIRI could be costly to implement, and it has to deliver a large number of services in order to be cost effective. And so when we try to integrate it into the routine service, that means the cost will go up, will be higher. And just keeping that in mind. But if there are domestic resources to implement PIRI more frequently, that would be, of course, ideal. But it depends on the resource availability. And we just have to be careful about doing it frequently and making it more or less cost effective by doing so. Thank you.
Great, thank you. And for Hadiza, in one of your slides, you showed both the cost per zero dose child reach and adjusted for all antigens. So if you could just kind of give a sort of short explanation on what the cost adjusted for all antigens represent.
Yeah, thank you so much, Christina, for that question. So the cost per zero dose child reach includes only the cost of reaching the children 12 to 23 months with the first dose of Penta. But the cost per child reach include all children reach with all kinds of antigens, whether it's the Penta or any other antigen, and so it's not only the first dose, it includes the second dose or the third dose of other antigens provided during the weekend vaccination sessions.
Great, thank you. We also have a question for Tahmeena. So we saw that zero dose children were identified through the polio house-to-house campaigns. But if you could just explain how the children identified for these campaigns were then linked to the routine immunization program.
Okay, so during the routine polio campaigns, these are the door-to-door campaigns. So when they are providing the polio vaccines to the children, they also check the children if they had received the Penta 1 dose or any injectable during the routine immunization. So if the child has not given the Penta 1 dose, so they record the name and the location of the child, and then make a record of these zero dose children, and afterwards the data is shared with the EPI. In some districts and in some provinces, the data is shared through an application which is called Synergy app. On this app, the polio vaccinators, they upload the zero dose data along with their address or some other unique identifier, and this data later on used by the routine EPI as well as these integrated programs to when they are conducting their sessions in the community, so they can vaccinate specifically those children. In some provinces like in Sindh, where they do not have these Synergy applications, so they just share the paper-based sheets with the EPI at the EPI office after every campaign, and from those sheets these are distributed to the vaccinators of their particular region to reach those children.
Great, wonderful. And just for Flavia, briefly, do you know what drove different in cost between countries across the different points in the synthesis?
Thank you. So there's many factors influencing differences in cost across countries, with the primary one probably being differences in input prices, with particularly labor costs or salary varying across country, and that driving some of the differences. And of course, whether each intervention was a good fit for each local context, that's also driving differences in unit costs.
Great, thank you. So since we're almost at time, I'd just like to thank everyone for joining. We will be sharing a recording of this webinar and the materials presented on our website, as well as responses to the questions which we didn't get to during this Q&A. So please check out our website. You can sign up for our newsletter there, and you can also find us on LinkedIn and Facebook. So I wish you all a great rest of your day, and thank you again for joining, and thank you to our speakers.
Thank you.